Although I probably need to make sure you understand neonatal coding is not like CPR. It is how you bill and how you classify disease states. So it's useful for physician and healthcare systems reimbursement, although we have to know CPR as well. So we're shifting from one end to the other. We're going from teenagers to neonates, and we're going from headaches, well, to the other end, let's just say. I have no relevant financial disclosures for this. Let me move this thing off of my screen. And then here are the objectives that I have listed out: to recognize the signs and symptoms related to necrotizing enterocolitis, to be able to identify the radiographic findings of necrotizing enterocolitis, and to be able to describe the benefits of human milk in the reduction and or prevention of necrotizing enterocolitis. We're going to shift back and call this NEC just because it's easier to deal with. In our world in neonatology, it's potentially a really devastating complication to babies. It occurs in the GI tract. Like many of the disease states we see, it is inversely related to gestational age and intuitively somewhat inversely related to birth weight. It ultimately is the most significant contributor to GI mortality and morbidity in preterm infants. Like a lot of what we do is poorly understood. I often tease with the interns that neonatology, we practice in three different areas. We practice science, art, and a little bit of voodoo. So I think as we continue to improve our understanding of necrotizing enterocolitis and NEC, we will be able to create better interventions to prevent and or treat it. It's a very heterogeneous group of diseases. We describe it as classic, transfusion associated, which we'll touch on in a moment, atypical, and then term. Most of this talk will focus on this classic form of necrotizing enterocolitis. The term babies can sometimes be just as catastrophic. I can recall as a resident, one of the cases that stuck with me across the years was a term infant in Well Baby Nursery who developed fulminant necrotizing enterocolitis and passed within about 12 hours from NEC totalis. And instead of babies that are term, it's often associated with congenital heart disease, from intestinal ischemia as a result of cyanotic congenital heart disease, and is obviously a much different form than a 6-week-old, 24-week gestation infant. The overall incidence varies between centers, and it ranges between 1 and 5%. I've already mentioned that it's inversely correlated with gestational age. In fact, most of our cases are in preterm babies. There's also a correlation between the gestational age and the interval between the birth and the onset of disease. You'll see on this slide, the median age at onset in an infant less than 26 weeks is about 23 days. Median age of onset in an infant who's greater than 31 weeks is about 11 days. So they have a tendency to occur between this 28 and 33 weeks corrected gestational age. There is some suggestion that African American infants may be at a higher risk. This predilection has been studied as recently as 2017. I can't quote the study on it, but I did go back and look to see what kind of evidence there was for it. And like a lot of things, there's a genetic predisposition, and we are just now exploring and trying to determine what that genetic predisposition is. I always found the geneticists to be fascinating. I don't know how they keep up with the amount of information that comes about and what seems like a daily basis. The signs and symptoms of NEC are typically nonspecific, like a lot of what we do in neonatology. There has to be an index of suspicion. In our babies, we see abdominal distension, we see gastric aspirates, we see feeding intolerance, bilious vomiting, and bloody stools. A notation on the gastric aspirates, we used to check those on a very regular basis. And in fact, now we rarely, if ever, check them because they are so nonspecific, and it can just be due to poor gastric emptying that we find residuals. So we try to stay away from using residuals as a marker for NEC, or really as a marker of much any disease states. Other signs and symptoms include lethargy, apnea, hypoperfusion states. You may see an abdominal mass. If you see an abdominal mass, that may be a result of a perforation or peritoneal irritation right under the site. Regression can suggest a fulminated kind of inter-abdominal process with septic shock, peritonitis, and death. Here I put up a couple of pictures of NEC, and you can see the physical findings. Here on the left, I hope you can see the arrow. You can see the abdominal distension, but you can also have an idea of this would be abdominal loops that are present that you can see. You may see tenderness and muscle guarding. Here on the right film, not only do you see the distension, but you can also see the marked erythema of the abdomen as well. I think I have this picture in here again, but both of those children are examples of how NEC may present. It's an old slide, and I like to keep some of my old slides, but what it's designed to show is the most common sign is abdominal distension. We also see grossly bloody stools. If you're a astute practitioner, you can determine whether there's abdominal tenderness. I've mentioned gastric aspirates. You can see a cult blood in the stool. We don't test for that a whole lot anymore. We used to do that at the bedside. Now that has to go down to the laboratory. Let's start bilious emesis, because bilious emesis is a big warning sign in neonates in general. Even in a term neonate, if you see bilious emesis, you have to worry about malrotation. You also have to consider whether there may be a volvulus involved in that as well. So bilious emesis is a big flag for us in a variety of disease states. You can also see diarrhea, which is also nonspecific. They can be related to feeding intolerance, formula intolerance, carbohydrate intolerance in our formulas. You can see that abdominal cellulitis, we saw the erythema and the mass. And you can see that these signs and symptoms decrease in frequency. Our laboratory evaluations are just as nonspecific, unfortunately. I always tell our residents again that our babies may get hot, they may get cold, they may be tachypneic, they may be apneic, they may be tachycardic, they may be bradycardic. Their temperatures go up, their temperatures go down. And so this is what we see with NEC as well. You can see leukocytosis or leukopenia. I still like to do the I to T ratios, but they're very nonspecific. An I to T ratio is where you take the immature cells and divide it by the total neutrophils. So you're thinking about things like bands, myelocytes, metamyelocytes divided by the total neutrophils plus the bands, the metas, the myelos, that sort of a thing. And a ratio greater than 0.2 is considered to be a left shift for us. Greater than 0.8 is considered dumping your entire bone marrow into the circulating system. I to T ratios are about as specific as inflammatory markers. I am not a huge fan of inflammatory markers. Our neonates live in an inflammatory state. So I don't find CRPs and procalcitonins to be that much help overall. And I think they're often misused because if they're elevated, people want to treat. And in fact, the approach to those are supposed to be, it's reassuring if they're normal. So I have a tendency to avoid those. Thrombocytopenia is often present. Disseminated intravascular coagulation can follow that. Electrolyte imbalances, metabolic acidosis, hypoxia, hypercapnia. But you see that every one of those are nonspecific laboratory findings in our babies. Radiographic evaluation, we typically see 3 or 4 things. So pneumatosis intestinalis, I'll show some pictures in a moment, is where you have air within the subserosal bowel wall. A pneumoperitoneum is where you're going to find free air in the abdomen, indicative of intestinal perforation. And portal air is where you have air that's tracked up into the liver. So here's a couple examples of pneumatosis intestinalis. Again, hoping that you can see my arrow. If I can find my arrow, I think what I've got it on is I've got 2 screens sitting next to me. Here it is. So they call this train tracking. You can see these marks through here. Also has some suggestion of them there. On this screen, you can see is down along in through here. This one's notable because this child has a hernia, and that's actually within the scrotal sac that they've shot this view from. Here's a picture of pneumatosis intestinalis at the operative field. And here's an example of portal air. Again, I hope the resolution is such that you're able to appreciate this, that you can see the air has outlined in the liver. This is generally a poor prognostic indicator if you see portal air on a radiograph. This is an example of intestinal perforation. Here you can see the free air that exists up under the diaphragm. This is the lateral view, a cross-table lateral, that you can see the free air that exists under the abdominal wall and above all the intestine. This was taken in a decubitus view. You can see the air that exists up above the intestines and the stomach. In this view, the liver side is down, so you're left-sided down on this. Ultrasound is becoming more and more utilized in neonatology and in our babies. Here you can see sonograms that show in the far left that the bowel wall is thickened. In the second one, it's thickened and has somewhat of a layered type of appearance. And the third one, you can see that the loops are distended as well. We are now starting to bring in point-of-care ultrasound into our units. We should be up and operational at Children's Hospital. We should be up and operational, period, at Children's Hospital. We're steadily increasing our utility of the use of point-of-care ultrasound. It's not meant to replace what we can find on formal ultrasounds by our radiologists, but it's meant to augment our ability to diagnose patients. This is another older slide, and this is how we stage NEC. We stage it from 1 through 3, and then we subcategorize it into A, B. You can see that there's a variety of different intestinal signs, systemic signs, and radiologic signs associated with it. Problem with this is not only is it an older method of staging, but when you're into stage 1, where you have suspected necrotizing enterocolitis, these findings are so nonspecific that they may alter what the overall incidence of necrotizing truly is. And in fact, you may diagnose some kids as NEC that truly don't have NEC. Here's a perfect example of a baby that would have mild abdominal stension, may have a little bit of blood in the stool, and an ileus can certainly be seen in a variety of other infectious states. It goes all the way down to 3B, where you have actual bowel perforation. This is a shot of a hemorrhagic intestine, again, a surgical specimen. And here we look at management. So the first of medical management is gut rest with decompression. So we would put a Rapogal tube down to intermittent suction. We would add antibiotics, typically ampicillin, gentamicin, and flagell or clindamycin. It's noteworthy that the anaerobic coverage, these babies often have a higher rate of complications defined as strictures. You want to correct any metabolic acidosis, and you want to correct any hematologic derangements and provide supportive care as needed. We'll consult surgeons to make them aware of the patient once we have the diagnosis made. Indications really are for surgical consultations, and potential surgical intervention would include an unrelenting acidosis, an unrelenting thrombocytopenia, shock, increasing distension, and certainly if you have a pneumoperitoneum where you have a rupture of the intestine and free air. That is another indication for surgical consultation and intervention. Surgical management is required in 30 to 40% of these patients. They can range from an exploratory laparotomy to a peritoneal drain. Peritoneal drains have really come of age since the time that I trained, and they seem to be just as effective as XLAPs in the smaller premature babies. They're used a lot of times where you see pneumoperitoneum and you're concerned about rupture of the intestine. It allows the intestine to heal while it decompresses. The basic component to this would be decompression, exteriorizing the gut. Overall outcome, the mortality rate is 20 to 30%. The picture on the right is a patient with fulminant NEC. It's the most common cause of death in neonates undergoing surgery, about 35% mortality rate. And again, like the other things we talked about, the mortality rate is inversely related to the gestational age. Those babies that survive often have higher rates of interventricular hemorrhage, periventricular leukomalacia, and they have worse neurodevelopmental outcomes. In fact, these babies would still be seen in our neonatal follow-up clinic. And I suspect with our new GI chief that we'll be looking to do some follow-ups together with the gastrointestinal when we think about things such as feeding teams. They have a significant complication rates for those that are in general pediatrics. Understanding that there's a history of NEC is important, particularly in a child who presents with recurrent or ongoing vomiting, because somewhere between 25 and 35% of these patients will develop some sort of a stricture. They can also develop short bowel syndrome. Short bowel syndrome ultimately is a difficult entity to deal with. You're talking about using TPN, potentially cyclic TPN, customized feedings, and they have a whole host of problems from bacterial overgrowth to malnutrition and so on and so forth. Babies can also develop intestinal failure because of the unrelenting inflammation that occurs. The annual costs for necrotizing enterocolitis is estimated to be between $500 million and $1 billion. We think that there's longer hospitalizations, there's an increased number of procedures, and they remain at higher costs for the first year after discharge. On those babies that require surgery, those higher costs are maintained through the first 3 years. On those babies that have necrotizing enterocolitis that have been managed medically, you'll see that the cost finally starts to normalize around 1 year of age, but it really doesn't bounce up like this line shows with the surgical NEC kids. So those kids who have surgical complications they have much more cost associated with the disease. Here's an idea of the mechanism. I told you that what we do is science, a little bit of art, a little bit of voodoo. So we think about mucosal injury, we think about bacterial overgrowth, and we think about abnormal flora, typically in the shadow of having been fed. So you think about hypoxia ischemia resulting in mucosal injury. You think about formula substrates contributing to bacterial overgrowth and the abnormal flora. And then you have to add for our babies that are the epitome of the immunocompromised host, the immature immunologic defenses they have and the immature gastrointestinal tract, along with the defenses that occur in there that are all contributors to necrotizing enterocolitis. We think about those immune states, we think about altered host defenses, the physical barrier, skin, mucous membranes, the intestinal epithelium, other biomedical factors, and then the different innate and adaptive immune systems. Here's some examples of deficiencies in the intestines for the preterm baby. We know there's decreased acid secretion. This actually is a suggestion as why we don't want to use proton pump inhibitors and other medications that alters that gastric secretion. They have decreased proteolytic enzyme activity. They have poor motility. They have reduced IgA secretions, reduced intestinal T cells, and increased permeability. And you can see a list of all the potential consequences that are associated with that. We can't really overcome these, but we can help alter these to some degree with the use of breast milk, which I'll show here in a moment. One thing that's important in the cellular immunity, while we have is listed up here the inflammatory phenotype of macrophages and decreased lymphocytes and shifts in T cell differentiation. Note this one, the TLR4 toll-like receptor activations. I'm going to show you in a minute how abnormal gut flora plays into this with these TLR4 receptors. What TLR4 will do is it increases cellular death, programmed cellular death, it impairs regeneration, and enhances pro-inflammatory responses as well. So if we have these things activated, it once again puts us in an inflammatory state. We know that there's dysbiosis, that the intestinal microflora is abnormal in our babies. We used to think that the uterine flora was sterile. In fact, that's not the case. We know that microorganisms begin to colonize before birth through hematogenous transfer. We know that premature delivery, the mode of delivery, breast milk versus formula, and also contribute to the different types of bacteria in our gut. Typically, the sequence is that they will develop bacilli in the gut, then it goes to gamma proteobacteria, and then to Clostridia. With NEC, what we see is a predominance of this gamma proteobacteria. And the reason I mentioned that one is because it enhances this TLR4 activation. Let's go back to that for just a second. If I have bacteria in there that activates this TLR4, it's going to increase my cellular death, impair regeneration, and enhance inflammatory cytokines. So the bacteria that's in our gut plays a significant role in developing necrotizing enterocolitis. Enteral feeding certainly plays a role. 90 to 95% of all infants have been enterally fed. But when you go back and you think about the mechanisms, we always have a few babies who develop fulminant NEC who haven't been fed. And that's primarily because of hypoxic ischemic injury. We can use that example of a term baby with cyanotic congenital heart disease. We think, though, that the feedings provides a substrate for bacteria and increases the risk of tissue hypoxia because it increases oxygen demand. As the intestine is contracting and trying to move food along the intestinal tract, as it's absorbing nutrients and trying to cleave proteins and sugars down, that sort of a thing, we think that all this may increase that risk of hypoxia because of the oxygen demand. We typically had thought in the past that if we delayed initiation and used slow advancements, we may be able to avoid NEC, and recent studies have determined that that may not be quite as impactful as we thought. In fact, delaying feedings may result in mucosal atrophy. Delaying feedings may result in bacterial translocation and dysregulation and secretion of trophic hormones, as well as increase in our overall risk of inflammation. So I think we're going to have to rethink our approach to how we're feeding babies. It impacts not only necrotizing enterocolitis, but you think these little bitty tiny preemies that we have now, 22, 23, 24 weekers, and we try to bring their feedings up full in about 10 to 14 days. We ultimately never really get close to that. It usually takes us a couple, 3 weeks to get up to full feedings. What the feedings do, enteral stimulation reduces cholestatic jaundice, it reduces osteopenia, prematurity, reduces physiologic jaundice, it improves our glucose tolerance, it shortens the time to full enteral feeds, it has a trochic effect on mucosal growth, it improves function. So one of the things we will try to do in the first couple of days of life is start some small amount of feedings. You think a baby in utero is always swallowing amniotic fluid. In fact, the concept is basically they're trying to prime the pump in preparation for feeding. And all these other things with enteral stimulation, all these other beneficial effects are there. We bring them out and take that away from them. So if we start with a small amount, at least to prime the pump, and then we can work our way up from there. Recent studies have shown there's no real difference between a slow advancement of 15 to 20 mLs per kilo per day and a quicker advancement of 30 to 40 mLs per kilo per day. I will tell you that there's absolutely no standardization across different units in the US. I don't see that at all. Human milk is the gold standard. It augments the immune system and it has anti-inflammatory effects that strengthen the mucosal barrier and beneficial to the bacterial flora. Our preference is to use mother's milk. If we don't have mother's milks available, we will use donor breast milk. Donor breast milk is homogenized, pasteurized, whatever ice you want to do to it. It does destroy some of the cellular components to it, but we know that donor milk still is better than formula. Mother's milk will have all kinds of good stuff into it that will include epidermal growth factors, platelet activating factors, secretory IgA is huge. We thought lactoferrin may be one of our big components to prevent NEC. It's got oligosaccharides, interleukin 10s. So you see all the different things that are part of the components of human milk. Donor milk appears to have a dose-dependent effect. I told you that all the different pasteurizing effects to it, freezing and thawing reduces the protective effects. But if you look at donor milk versus formula-fed babies, you're going to see formula-fed babies still have over 2.5 times the risk ratio versus donor milk. You can use donor or breast milk for less than 7 days in the first month of life and increase your risk of NEC fourfold. So all of our hospitals, all of our units have protocols for the use of donor milk. Not only do they have protocols for the use of donor milk, but we have protocols used for human milk-based human milk fortifier. I have to say that slow because I will slur it if I don't. We know that multi-center studies have found that human milk-based diet, including human milk-based human milk fortifier, reduces the incidence of NEC, late onset sepsis, ROP, BPD, and mortality. So all of our units also use a human milk-based fortifier. The last couple of things I want to hit is the role of transfusions. There's no standardization among institutions throughout the United States. We have a couple of listservs that we work off of from clinical leader groups associated with the American Academy of Pediatrics, the division chiefs, and that sort of a thing. Our question is it the chicken or the egg? So there are some studies that suggest transfusions are associated with NEC. Their randomized trials show that transfusions are associated with a lower risk of NEC. The top trial looked at threshold for transfusions. We didn't see any difference there. Retrospectively, we've looked and decided that withholding feeds seems to reduce transfusion-associated NEC. To prevent it, we would suggest evidence-based medicine. You could also say EBM is expressed breast milk. I like that idea too. Combination of measures has the highest potential for decreasing, standardizing your feeding protocols, mother's milk, donor's milk, strategies to avoid alteration of the intestinal microbiome, such as antibiotic stewardship. Used to be the only thing you had to do to get antibiotics was cross the threshold. Now we're a lot better about not doing that. We avoid anti-reflux medications. We're looking at probiotics, but they are so poorly regulated that we find that topic to be very controversial. We have not adopted use of probiotics. Thank you for that. I'd be glad to take any questions.
All right, thank you, Dr. Duncan. So a lot of on deliveries, they do cord pH now, and so is there a pH like a low pH where you would delay feeding a child?
No, that there's a low pH. I think the idea is to look at the overall appearance of the baby, try to put the entire picture together. And I talk to residents about that a lot. We rely a lot on single isolated radiographic studies, laboratory findings, whatever it is. But I think you have to look at the totality of the clinical picture. A child who has had those low pHs, that hypoxic ischemic type of an injury, we may delay feedings on that baby. And the time that you delay it is you can take a dice and throw it and pick a number out of it because nobody has a good feel for that either.
Okay, and then is donor breast milk tested for CMV?
Yes.
Yes.
All our stuff should be tested for CMV because in the first 28 days, if you diagnose it, that's considered congenital CMV. So all that milk, like I said, it should be homogenized and pasteurized. All the milk banks have standard protocols they work with.
All right. All right. Thank you, Dr. Duncan.
All right. Thank you.